Thank you all for coming. It's great to see such a large turnout. And before Dr. Allison goes on, Dr. Mittman is going to give a few opening remarks. So.
Hi. Actually, I was just asked to introduce Dr. Allison, and I have to say that I am honored to be asked to do the introduction, number one. And I'm also very proud that among the many clubs, this is probably for students for whom time is probably your most precious resource. That you have such a big turnout for Dr. Allison's presentation, which speaks to three things. Number one, you had food. That's a good idea. That always helps. Number two is the stature of our speaker today. She is a cardiologist. She is a top doc. She's been in practice for well more than 20 years. She is, in addition to being a physician, she is a spokesperson in the LGBTI community, and particularly for individuals who are going through the process that that many people who identify as transgender need to deal with in a culture that is increasingly more accepting, but in a healthcare system that really has yet to catch up in many of the ways to where it needs to be today. And so to be a resource for not just that particular community, but for everyone here, speaks to her, her incredible career. And so we are very honored to have her here. And then finally, I'm also really proud that people here understand that that diversity at SCNM is not about the particular club or the particular constituency that's named in the club, but that it's important for each of us and for you guys as future physicians that you need to really understand everyone who you will encounter when you're in practice. And so this is as much for people regardless of how you identify as it is for the members of the LGBTI club. And so without further ado, it is a great pleasure to introduce to you Dr. Rebecca Allison.
Thank you, Dr. Mittman. The first words the speaker utters are, "Is this thing on?" And I'm supposing it is, and that you can hear me. If not, I'll just talk louder. It is my pleasure to be here at SCNM, and I've really enjoyed working with Christian, Wendy, and the LGBT Health Initiative group. I'm aware that the size of the group is somewhat smaller than the size of the audience today, and I echo Dr. Mittman's appreciation for all of you supporting our LGBTI students. So I think you have some handouts. Hopefully we had enough to go around or to share. I have a few more down front if anyone doesn't have access to them. So I'm guessing that you do have a little bit of familiarity with some of the facets of LGBTI life and know some gay and lesbian friends and colleagues. But how many of you can say that you've never really met or dealt with a transgender person? Look at your hands, because this is the last time you'll ever be able to raise your hand. If you're going to be truthful, because you just met one. We, don't have green skin or 5 arms or anything like that. We're not freaks. And we have a lot of health needs that I want to discuss a bit with you. Many of you will go to your chosen communities when you graduate. Your primary care will be your focus, and you will see people who walk through the door with all sorts of problems. And I hope to talk to you today a little bit about these patients and the unique needs that they have. In some ways they are not unique, they're just like everyone else, but there are some things that I want you to be aware of today. And we have a couple of seats down front. But a little bit about me. Basically, I do practice cardiology, as you heard, in Central Phoenix, and have been here since 1994. I grew up, and this will come as a complete shock to you, I'm sure, in the South. Mississippi, to be exact. And in that place and in that time, it was not healthy to admit that you didn't quite understand what was going on with your body or your gender. So you don't. You buy into the idea that this is wrong. You think if you pray hard enough, you can be healed. So you buy that, you try that for a number of years, and it doesn't work. You become very despondent. And then you connect to your community, and you realize, hey, other people are like this too. Other people have made this work, and I can too. So even as an adult, it's possible to accept who you are, to start the transition process, and to have a normal life in every way, living your dream as a person that you thought you could be. In addition to my medical practice, I have been active in LGBT activism, politics. I have been on the board of directors for the Gay and Lesbian Medical Association for about 10 years now, and I'm a past president of the association. We've done a lot of advocacy for LGBT patient rights and also for LGBT healthcare providers. I invite you to go to the website of glama.org and learn more. We are a diverse group and have all sorts of health professionals as part of our membership, and would welcome your interest. So I want to talk a little bit about healthcare needs of the lesbian, gay, I'll talk about the LGBT, if you will, today, transgender, lesbian, and gay population. And if you have the paper on transgender, 10 things transgender persons should discuss with their healthcare providers. You look at number 1, and I could spend the rest of the hour talking about access to health care. There are parts of the country where a transgender person cannot get health care today because we don't believe in your kind. It happens. I keep getting emails. Despite all of the advances, despite what we see with the current medical climate, the Affordable Care Act, the advance of the electronic health record, there are still places where a transgender person can go into the emergency room and lie there without being treated. I know because this happened here in Phoenix to one of my best friends. She injured her back, and the emergency room physician stood at the door of the room and said, "Oh, it's probably just a sprain. I'll give you some ibuprofen." She called me. I came in. I said, "You're getting an X-ray." The X-ray showed a fracture of the fourth lumbar vertebra, and she got appropriate treatment. But if she hadn't had an advocate, you can imagine. People don't feel comfortable going to their provider in such cases. They don't know whether that provider will listen to them, take their history properly. Many of us have to educate our own providers because they don't know the questions to ask. They never saw a transgender person either until now. And so while we do have textbooks now, transgender medical care, we don't have a high readership in many places. And if I were to be giving this talk at the American College of Physicians meeting, I would probably have 1/3 of this classroom filled with the interested physicians who go there. So that's another reason I'm so impressed. But access to care is made more difficult by the front office staff. The person checks in. Sometimes there is a little discrepancy between, "Hello, I'm Mary, and I'm here to see Dr. Smith," and the receptionist looks up, and "You don't look like any Mary I ever saw." So she says, "Okay, have a seat, sir." And you know right away this is not going to go well. But using the correct name and the correct pronouns are little things. They're easy. They don't hurt you. And anyone can practice common courtesy. When a person is trying to present in their desired gender, to completely disregard that is a sign of disrespect. I don't approve of your life, of what you're doing, so I won't acknowledge it. When the person is called back to the examining room, the assistant may have the same issues. And then when the provider comes in, they may not even listen to the patient, but just tell them what they're going to do. Getting a good checkup, prescribing the right treatment, forget it. The electronic health record should be beneficial, shouldn't it? I mean, this is a wonderful advance. We can look up anybody's health record across the system. But what's the problem that transgender people face with the electronic health record? You got two choices for gender. You got male and you got female. So suppose I am a pre-transition or early transition person going to the physician, and I say, "Put me down as female." They say, "Okay, we'll do that." Now, how about your pap test? And I'm like, "No, I need a prostate exam." So you can't have that, you're female. We have a lot of work to do on the electronic health record, as well as on the workings of healthcare administration to take into account the gender options, male to female, transgender, female to male, genderqueer. Everybody heard that term? People sometimes, especially younger people, don't want to identify in the binary. I don't feel like a guy, I don't feel like a girl, I'm just me. How do they get health care? We're still working on that. this is a plea for diversity, tolerance, gender fluidity, if you will. There are people who present as one gender at times and as the other at other times. That shouldn't be a crime. It shouldn't be a reason to deny health care. If a person is able to get an appropriate provider who is empathetic and understanding to a degree that the patient doesn't have to do all the teaching about here's what you do with a transgender person, they're very fortunate. I put health history as a second item in 10 things transgender persons should discuss. And the truth is, many trans people don't talk about their health history to their provider because they don't want to bring up old hurts and old shame. They think it's shame because they've been taught to be ashamed of their past. And we need to eradicate that internalized phobia, that shame from people's lives, so they'll be willing to say, yes, you know, I was born that gender, but I'm transitioned now, and these are the issues that I had to deal with before, and this is what's happening now. An honest health history will go a long way towards a good provider-patient relationship. The number one concern of a lot of transgender people is, are you going to help me get my hormones? Certainly understand that. And if the answer is no, then the trans person walks out of there and gets on the internet and finds out where I can order them on the black market. Trans people are going to get hormones. I mean, that's just part of the psyche there, and it's a lot better if they can be obtained under control, under laboratory monitoring. What all do you have to monitor? Well, you've got to monitor a lot of blood tests, liver functions, cholesterol, complete blood count, electrolytes. Some of the hormones, like spironolactone, has a hormone-like effect. It's a diuretic, and you need to watch the potassium and sodium and the urine creatinine kidney function. Monitoring the blood sugar. Sometimes people taking high doses of estrogen can get elevated sugar, elevated triglycerides, a pre-diabetic type of condition. I'm a cardiologist, and one of the things that concerns me is estrogen's effect on blood clotting. And I tell people that if you're someone with other risk factors, like if you are male over 40, biological male over 40, you know, you're at some risk, and you need to be taking aspirin a day if you're going to take the hormones also to help prevent the blood clotting. Even so, starting on hormones does carry a small but real risk of blood clots in the legs and the lungs, sometimes even in the heart, over the first months or year, and then that risk seems to become less as time goes on. But it's still a red light to keep monitoring people for heart disease. And what's the one thing that I tell all these people who are going to be starting on hormones as far as their personal habits are concerned and their risk? Throw the cigarettes away. All three of these papers discuss as one of the 10 things to discuss with your provider tobacco use. Tobacco is very prevalent in the entire LGBT community. Stress relief, weight maintenance, whatever. Once it's started, as many of you may know, it's hard to stop because it is physically addictive. people who smoke and take estrogens have perhaps a 20-fold risk increase for heart attack and stroke. So it's just imperative that we insist that they stop. I put in here about cancer, and people wonder if taking hormones will increase your risk of cancer. For example, will estrogen increase a person's risk of breast cancer? And the answer is, we don't have any evidence yet that it does. There have been, in all the medical literature, less than 10 proven reports of transgender women developing breast cancer. It's not to say that it never happens, but the breast cancer usually involves the glandular tissue rather than the fat distribution, and doesn't affect the biological males taking estrogen so much. What we do worry about, cancers that pertain to the birth gender. For the male to female person, this would be the prostate. Now, it's true that treatment for prostate cancer is orchiectomy and estrogen. So that puts many male to female people at a low risk because that's part of the transition process. But still, prostate is not removed in surgery, and it continues to pose a theoretical risk. More concerning are the risks associated with the person transitioning from female to male, because it's possible for testosterone to have some effects on the ovary. There have been several documented cases of ovarian cancer in persons transitioning to male who did not have the finances or possibly the wish to have a hysterectomy. So these people did not seek attention until the pain in their abdomen became intense or the swelling became noticeable. But it was too late. There was a movie which you probably can find somewhere on YouTube or iTunes called Southern Comfort. Southern Comfort, besides being the name of an alcoholic beverage, is also the name of a gender convention in Atlanta every year, which draws upwards of 1,000 people. And the person who the movie is about lived in Atlanta. I actually had met them in the early 1990s, and could not find a gynecologist in the state of Georgia to treat him. And by the time he was able to find someone out of state, cancer was widespread. So this is the kind of difficulty that we have faced through intolerance and lack of acceptance. Sexually transmitted diseases, safe sex. You might say, well, isn't this something that we should worry about more with gay men? And obviously the answer is, well, yeah. We'll talk about that in a few minutes. But think about this. Here is a young transgender woman who can't take it anymore, can't wait until they're 18 and on their own, got to come out, got to tell Mama at 14. What does Mama do? Throws them out of the house. Says, don't ever come back here again. You're not my child. What's that child going to do? If she's very, very lucky, she can find someone to take her in a group home setting and nurture and mentor her and get her through high school and find some way to support herself. And how many are really lucky? Not that many. So if she's in a big city, how does she raise money? And yes, the rate of sexually transmitted diseases, the rate of HIV in young transgender people on the street is extremely high. It's catch-22. Then the people who don't believe that anyone should be transitioning will say, oh, look at that, you know, this has just destroyed this person's life. Look at what they've done to themselves. No, look what you have done to them by your lack of acceptance and love. So we worry a lot about our young population, and we talk about safe sex. Obviously, it's not what some Johns want. But we try harm reduction. We try to get people to use protection whenever they can, because we know that just say no isn't happening. So we talk about tobacco, we talk about alcohol, and I don't think there's a lot of difference with trans people drinking as there is with anybody else, except for the fact that estrogen does sometimes stimulate the liver to go into overdrive and produce some liver enzymes. And if a person's got a drinking problem and getting alcoholic liver disease, then the hormones may have an excessive effect on that person. And we do emphasize drinking in moderation or not drinking at all if you can't handle it. So we talk about depression, talk about all sorts of behavioral issues. People wonder, are there higher rates of depression in LGBT people? What do you think? Hello. We have some reasons to be depressed sometimes, and we have a lot of people who harm themselves. Another of my dear friends went through a time where she tended to cut herself, and that person was an inpatient in a few mental health facilities. She got out, she finished college, went to medical school, and is in a family practice residency as we speak. But she went through severe depression because, yes, her mama kicked her out of that house. Don't know if there's an increased prevalence of Asperger's with LGBT people. Sometimes I think it may be, but I think that we don't do a very good job of making that diagnosis anyway, and it may just be a reflection of the general prevalence in the population. What we do know is that the rate of attempted suicide in the transgender community is somewhere in the neighborhood of 40%. I never attempted suicide, but I thought about it. And I thought how I would do it. That would be the closed car and the engine running. And the reason I thought about it was way back in the early transition, way back in Mississippi. Did not go well. I lost my job, lost most of my friends, quite a few of whom have come back, but it was rough. Lost my family, I lost a whole pile of money. And yeah, I was depressed. Yeah. But really wanted to see how this was going to turn out, and I'm glad I did. 40%. Now, sometimes it's not so much of a true attempt as it is a cry for help. But that's real. If that cry goes ignored, the next time is serious. A lot of times, it's an overdose. But mental health concerns for all LGBT people are underappreciated. The last couple on the list, well, fitness, I mean, I'm not going to spend a whole lot of time about that, other than saying it's really easy nowadays for anyone, not just LGBT person, to sit on your couch and play, what do you call it, World of War or something like that, whatever, or, you know, massive multiplayer role games, you know, until wee hours of the morning. That's not very healthy. That's not getting you out to the gym and working out, and you're eating munchos while you do that. So, you know, we're raising a generation of kids who are really good with their thumbs, but are way out of shape and not going to do well in later years. So fitness is a big deal. Injectable silicone. You say, what? What are you talking about? Hormones take a long time to work, like years. Some people are impatient. They want to have big breasts and a big butt, and they want it now. They want cheeks. And it has been learned that silicone can be injected into breasts, butts, and cheeks and fill them right out. Magic, isn't it? No. It's deadly. How can it be deadly? Well, number one, where do you go to get this silicone? You don't go down to your local plastic surgeon and get it, I can tell you that. You go to an underground, we call them pumpers, and they have pumping parties where people go and pay their substantial amounts of money, and these pumpers get injectable grade, industrial grade silicone, which may or may not be sterile. The needles that they use may or may not be sterile. And they inject through big needles large amounts of silicone, and they can see instant results. Oh yeah, look at those cheeks, girlfriend. You know, you are just really looking great now. Best case, girlfriend looks good for a year, and then it starts to sag. Now, silicone's liquid. You know, it's not likely to get encapsulated, and if it does, you don't want to see what it looks like. But it's liquid, and it will migrate down. It will migrate out of the breasts, into the abdomen, out of the butt, into the legs. We have seen awful, awful pictures of these things. Again, I say that's the best case. The worst case is the pumper injects it into a vein, goes directly to the lungs, and they die right there in the hotel room with pulmonary embolism. There was a case last month that you may have read about online where this exact thing happened. And of course, it happened to be a transgender person who was doing the pumping, and that wasn't a very good thing for community reputation and publicity, as well as just being the tragedy that it was. So I always try to discourage. One of my friends designed a publicity campaign called Dangerous Curves Ahead, and complete with road signs, and to tell people this is not the way to get that body shape. It takes time, but it's worth it. So I want to switch gears, talk a little bit about lesbian health. And then the top 10 things lesbians should discuss with a healthcare provider. All of these come back to access to care in one way or another, because there are many people who likewise disapprove of the gay and lesbian, quote, lifestyle. Do me a favor, don't ever use that word. Lifestyle. It's not a lifestyle, it's a life. Lifestyle is pejorative, it connotes disapproval, and just be empathetic and don't do that. Lesbians are more likely to have risk factors for breast cancer, such as being melliferous, yet less likely to get screening exams. And every woman needs to know breast self-examination, needs to perform it once a month, and needs to have a provider who will do breast exams once or twice a year. Mammography is important. I'm not quite as big on annual mammography because I think that's a whole lot of X-ray exposure, but I do think that once a person gets to be over 40, that they should have periodic mammography every few years to detect problems before they become palpable masses. Again, the depression and anxiety are worse sometimes with women who need to be in the closet and not be out about their sexual orientation. If you look down at number 9, also, this is something that we are not as cognizant with, intimate partner violence. It's not difficult to think of violence to a woman in a heterosexual relationship because you got this big old guy who gets drunk and beats her up. But guess what? This happens in lesbian relationships. And I have had friends whom I've met through the medical association who are survivors of intimate partner violence, which has been fairly brutal. And if you don't know it and the person comes in the emergency room saying, I fell down the stairs, you won't know to ask the right questions. Sometimes they need to be able to move out of that environment into a safe space. Heart disease is the leading cause of death for women, as we like to emphasize, not breast cancer, although breast cancer is a dreaded thing, but heart disease kills more women every year than breast cancer does. And again, smoking is very, very prevalent in the lesbian population, and many women do this to keep their weight down. Overweight is a very common problem. Body self-image issues and lack of activity are widespread. And so all the issues that go along with heart disease risk, and especially in overweight persons, diabetes, cholesterol, blood pressure, need to be frequently investigated. GYN cancers are still as common, if not more so, in lesbian women. And very many do not get Pap tests on a regular basis, do not get pelvic exams, exam for ovarian size, for polycystic ovaries, which are not uncommon syndrome. PCOS is possibly more prevalent in the lesbian population, and especially in the female-to-male transgender population. And then we've got substance use. We've got same things, and reducing stress by healthy ways other than a drug is very important. People think that lesbians can't get sexually transmitted diseases. Anybody get sexually transmitted diseases doesn't always involve penis. And people should be encouraged to report pain, lesions, blisters, herpes. It is quite common. HPV is not rare, and we think about sexually transmitted diseases of the genital organs. We need to think about oral manifestations also, so be sure and do a thorough oral exam on your patient. Now, if you have the paper on 10 things that gay men should discuss with healthcare providers. Again, on number 1, come out. And if you don't tell your healthcare provider that you're a gay man in a relationship with a man, then they don't know to go down that road of investigation, and they're not going to examine you, screen you for many of the sexually transmitted diseases that we're going to talk about now. And if your provider does not seem comfortable with you as a gay man, find somebody else. Here in Phoenix, there are a number of providers who are gay and lesbian, have a large practice. And the website, gnma.org, can help you with that also. And we, again, would welcome your interest and participation. If this is something when you graduate and go into practice that you would be willing to treat and be interested in listing, there are provider directories on our website at GLMA and others available where you can let people know, yes, I can treat you and I understand and I'm skilled. There's an entire discipline of medicine now devoted to HIV medicine, and it's certainly beyond the scope of anything that I can tell you here. Obviously, you know that HIV has changed from a disease that everyone dies with to a disease that a lot of people live with, and live with for decades, and highly active antiretroviral therapy has changed the picture so much, and people do survive with their antiretroviral therapy, and we see them, I see them in my heart clinic, because they have heart disease like many other people. Sometimes the drugs that they take will do strange things with the lipids, the cholesterol and triglycerides, and we have to be aware of that and help to keep that under control. There's also the issue of post-exposure prophylaxis that is considered here, and that is something that can be effective if a person has unprotected sex with an HIV-positive person. Then if they are treated appropriately within the first day or two, their chances of becoming positive are greatly reduced. And the community needs to be made aware of that. We can know it, but if the people who are out there in the community don't know it, they won't know to seek attention. There are a lot of sexually transmitted diseases. They talk here about hepatitis, and especially Hep C, is the dreaded form of hepatitis, which goes into liver cancer more often, or chronic cirrhosis, liver failure, and is a endpoint for people who have a lot of unprotected sex sometimes, or unprotected drug exchange, needle sharing, and so forth. Hepatitis is something that can be detected on blood testing without too much difficulty, and is certainly encouraged in terms of screening for liver enzymes a couple of times a year at the minimum. People who are practicing safe or unsafe sex. The other STDs that have been around for a long time, syphilis used to be the most dreaded, most serious one. It's treatable and in an early stage curable. If it goes into advanced neurosyphilis or cardiovascular with the aorta, then it's a difficult thing, and we are reduced to dealing with the complications at that point. So that's another thing that needs to be diagnosed at a very early time. And there are the conditions like chlamydia and gonorrhea, which cause a lot of local problems and do need to be treated and cleared themselves, even though they may not be an urgent threat to a person's life. Cancer in gay men, again, is sometimes undiagnosed because it's unsearched for and people don't see the doctor and don't get screened. Testicular cancer is not a rare thing, and people often don't get examined. A good doctor will have reasons for your gay patient on why you should get examined, and be able to assure them that this is a part of a complete checkup. And did I mention HPV, human papillomavirus, is the sexually transmitted disease that causes a lot of anorectal problems. Genital warts are extremely common. Anal cancer is unrecognized for a long time and can be metastatic, can be a cause of death for anyone who has receptive anal sex. So these are things to be alert for and to ask about in a sensitive manner. There are tests, including anal pap tests, which can be done now and are very sensitive in making correct diagnosis. It all comes down again to comfort levels of the patient with the provider, and the provider with the patient. And if you don't have a comfort level treating LGBT patients, ask yourself why. Consider why you, going into naturopathy, you're becoming a healer, and yet there's a group of people that you don't want to heal. How is this consistent with your ethics? I hope that I have raised a little consciousness at least, and caused you to have some questions of your own. I will be glad to, in the short time we have remaining, try and answer a few questions if you have.
So whether it's supportive or preventative, what is kind of the role that UBC naturopaths play in the LGBTI community?
Patient education is very important. I think that if you are aware of these risks than the people who come to you and pick up on any red flags if their person to contact, is a person of same gender, or then you just can gently go down the road of are you happy with yourself sexually, and are there things that you need to discuss or have questions about, and just leave it open-ended. Don't pin them down on little specifics, but just say, what questions do you have in your life about your sexual life and your sexuality, and just assure them that you're someone who cares and that will keep their confidence that you can be open with me.
I had a question about insurance. If they find somebody that they're comfortable with as a provider, and their EMR says that they're female, but biologically they're male, does insurance cover the prostate exam?
Many insurances now do not. And insurance companies just love to not cover things. So if I put in a request for a PSA blood test, they're not going to cover that. No, I'd have to pay for that out of my own pocket. That needs to change, and we are lobbying for that to change, along with the EHR allowing different diagnostic criteria. So we can say, okay, you have male, female, male to female transgender, female to male transgender. You need to cover pap smears for female to male transgender people. And I think we're going to succeed with that. But it's just, they have to be dragged kicking and screaming into paying more money.
I want to make a comment and then I also have a question for you.
Yes.
I've been a registered nurse for 18 years, and I've never even heard of this rectal pap smear. I think some of the, when you said when you're uncomfortable treating the LGBT community, I think a lot of that is just ignorance and
yes.
uneducated. Yeah, because I was never taught that, and I never saw it in clinical practice. And then also the question I have for you is, in treating this community, what has been the biggest challenge in terms of obstacles to care that you have experienced with the community, and also how have you addressed that?
Young LGBT people, especially young transgender people, look at me as part of the establishment. I'm a well-to-do, older, white person who doesn't understand them. And I have to break through that. I have to say, I've had some of the experiences, not all, but I've had loss. I've experienced rejection. I know what it's like. And I know enough to not be rejecting of you. The problem that so many of us face is that kids have to reinvent the wheel. They don't believe a lot of the stuff that we tell them. That they're going to go out there and do their pumping parties, and they're going to go out there and we didn't even talk about meth. We didn't even talk about cocaine, but we could talk about all those things that they're going to do too. And I would say that it's an age thing.
We have another class about to begin, and so if you're okay spending a little bit of extra time out in the hall, we would be sure there are several people who may have some lingering questions. Is that all right? Before everyone goes, just from a call to action standpoint,